Welcome back. Today we're going to be discussing Chapter 15, which covers communication and documentation. This is a very important chapter. It's relatively short, but this is critical to everything that we do. If you can't communicate and document well, it doesn't really matter how good of a provider you are because you can't effectively communicate your treatments to others and continue care. So that renders a lot of your care ineffective if you can't effectively communicate with others and effectively document what you did and what you saw. I do apologize ahead of time. I am a little under the weather today, so my voice might be a little bit off and I might not sound normal. So I do apologize for that. But that being said, let's dive into this chapter. So we'll be discussing different types of communication systems we use in EMS, especially radios and how they work and different components of them. We're going to talk about the verbal report that we give to the hospital, talk about interpersonal communication with others, as well as therapeutic communication. The pre-hospital care report, that's what we refer to as your chart, and then some special legal issues that we come across with documentation. So through the course of a call, we use several different types of communication devices and systems. First and foremost, we have our radios. That's our two-way communication between dispatch and us, so they can talk to us, we can talk back to them. A lot of places have one-way pagers or alert systems. That's where dispatch will send tones to your agency, and anyone that has a pager queued to that tone will go off and alert you that you have a call. That way you don't have to listen to the radio constantly to figure out if you have a call or not. It will specifically alert you. When you've been in class, you've heard the tones go off for the agency to go to calls while we've been in class. One thing that we're using a whole lot more nowadays are cell phones. Cell phones we can use to make phone calls. Sometimes we can text people. I've texted my medical directors on calls before. Another thing that we have are apps. We have, most people have heard of things like I Am Responding or Active 911, where calls can be sent directly to your phone and you can get the notes straight from the 911 center to your phone so you know what's going on. And then we have in most areas nowadays things called mobile data terminals or MDTs. Those are computers in your vehicle that is connected directly to the 911 center. That way, when they get notes on the call from the call taker, you get those notes in real time as well. And also, it cuts down on our need to talk on the radio itself because most MDTs have functions where you can push a button saying that you're en route. You can push a button saying you're on scene. You can push a button saying that you're transporting. In Onondaga County, you can even type in the clearance to the hospital, so you can type in what type of patient you have, and it's sent that way, so you aren't having to take up radio time saying this stuff over the air. So MDTs are the way of the future, and like I said, most areas have them nowadays. And it really cuts down on our need to take up airtime, so it can be saved for critical transmissions. So going back to radios, we have several different components of radios. You have things called base stations. Base stations are your dispatch center or maybe the hospital, kind of a centralized location of a main source of the radio communications. So your 911 center is typically your base station. Mobile radios are radios that are mounted inside of a vehicle, so you can't just take them out. They're usually screwed in, and they're called mobile because you are driving around. You're mobile with them. So mobile radio is one that's actually in your vehicle and does not leave. Portable radios are ones that are in your vehicle that you can pick up and walk around with. Those are the nice and small ones that are portable with you. Repeaters are things that are kind of the past now, but they do still exist in some locations. Repeaters will take a signal and then amplify it. A lot of fire trucks in the past had repeaters actually on them. So they would take a signal from your portable, which wasn't a very strong signal. It could only go maybe a mile, and it will capture that and then repeat it at a much higher amplification. So instead of going 1 mile, it could go 20 miles. So repeaters can either be mounted on vehicles or they can be actual towers. So their job is just to take a signal and then amplify it to a much bigger area. There's also a term called telemetry. Telemetry is the sending and receiving of data. So if you transmit a 12-lead EKG to the hospital, that is transmitting data, so that's called telemetry. A lot of people in this area refer to telemetry as contacting the hospital, contacting medical control. So if you need to contact medical control and let them know of a patient that you're bringing in, a lot of times we'll say that we'll be using telemetry because that's contacting the hospital. But in its true definition, telemetry is the sending and receiving of data. So telemetry is more commonly associated with actually transmitting something like a 12-lead EKG, which we'll talk about in cardiology. So here's just a quick picture of how everything works. So right here we have the ambulance, so that's the mobile unit. The ambulance will shoot the signal to a repeater tower right here. Then the repeater tower will bring it all the way over here. And then we have our dispatch center, which is our base station. So you see the base station tower right here for our dispatch center. And then you have a portable here, which also can ping to a repeater. So just a quick visual of how everything works. So our radios are controlled by the FCC, that's the Federal Communications Commission. They're the ones who give us our licenses to operate radios, and they assign us the radio frequencies to use. That being said, it is monitored by the FCC. It is a governmental monitoring agency. So you have to utilize appropriate language. If you swear over the radio, you could be fined by the FCC for doing that. So be mindful that you are on a public channel that is monitored by the FCC. So keep your communication very appropriate and professional. And they do have a lesser rules of what you should and should not do. Make sure you follow those rules. It's generally common sense. Keep it as brief of a communication as feasible, and keep it professional and appropriate. So this is a table taken from your textbook. We won't go over it right now because you can look at it in your textbook. This is just principles of radio communication that the FCC says. So going through general principles of radio transmissions throughout a call, typically a 911 call comes in from a telephone. Sometimes it will be sent to an agency via radio. So sometimes a caller will be connected to, say, Onondaga County when the call is actually in Oswego County. So Onondaga County will radio Oswego County over what's called the FireCom and say, hey, we have a call for you guys. And then that's how they get the call. So it could be done over the radio, or say someone calls AMR directly and it's a call for a county agency. AMR will do the same thing. They'll radio over to Onondaga County Dispatch and give them the call. So typically it comes from telephone, but it could come from a radio source. It is critically important that our dispatch centers get the information correctly and that they communicate it to us correctly. Otherwise, we're going to wrong addresses, which is both bad for the patient and very embarrassing for us. That's one of my pet peeves, is either driving by a call or going to the wrong address completely. So always make sure that you verify the address several times that you're going to the right address. One other point with our radios is if two people try to talk at the same time, only one will go through. With the digital systems, if you try to talk when someone else is talking, you'll just hear a very low tone. It'll go for you, and that lets you know that the line is busy at that time. So be aware that that means someone else is talking, so you should take your finger off the mic, let the transmission finish. But also, when you are talking, be aware that no one else can talk while you are talking. So if a crew is on scene and they are being attacked by someone and they need to radio for help, if you're taking up that channel, they can't get their transmission for help through. So that's why it's very important for us to stick to the minimum amount of time that we need on the air to effectively communicate. Don't cut your communication short so that it's confusing, because then we're going to have to clarify that it takes up even more time. But don't hog up the air by saying a bunch of stuff that is not necessary to communicate. So it's a nice balance, a nice give and take when you're on the radio. So remember, when we're doing anything in the medical field, which includes dispatch, we're using the 24-hour clock. So it starts at 0000 and goes through 2359. So be accustomed to using that clock. One thing I did when I was new was I set my watch and my phone to be on the 24-hour clock. That way I was comfortable using it and it wasn't some big math equation that I had to do. Sometimes when you communicate with dispatch, whenever you send a transmission, they have to acknowledge that they received it. And sometimes when you do that, they will just say the time. So if I say that I am on scene, so I'll say Eves 2 on scene, they can come back and just say 1824. That is their acknowledgement that they heard me. So be aware that they might just say the time, and that means that they heard what you were saying. One thing that I'm notoriously horrible at is carrying the portable radio when I get out of the ambulance. It is something that you really have to get in the habit of doing, because if you don't have your portable radio, you lose your lifeline for communication. So if you are getting attacked on scene, you don't have a way to communicate that with dispatch. If you find you need additional resources, which is part of our scene size up, so say you get inside the house and you realize this person's unconscious and 400 pounds, you need a way to communicate that with dispatch so you can request your additional resources without leaving your patient, which that, as you remember from medical legal, could be counted as patient abandonment. So it's very important that you carry your portable radio whenever you leave your ambulance. This even extends to when you're not on a call, because say you are in your ambulance or fire truck and you go and you stop and get food. When you're outside of there, you can't hear dispatch. If they need to get a hold of you, say they have a call for you or they have something they need to tell you, if you don't have your portable on you, you won't be able to hear them. So get in the habit, whenever you leave the vehicle, make sure you have your portable on you. So most regions require that you send a notification to the hospital before you arrive there. That way that they know that the patient is coming. Different counties do it different ways. I used to work in Monroe County, which covers Rochester. Rochester, if it was a basic patient, they did not want you contacting them. So they are the exception to most areas. They didn't want any communication unless it was a critical patient. Onondaga County, they take the information, which is very, very basic, and usually you put it in through your MDT. So you can type in your MDT very, very basic stuff, such as 21-year-old female, BLS care to Kraus, complaining of abdominal pain. That's all they want. And when you enter that, that goes to the dispatch center. Dispatch center will then type it into a online program, which then sends a page to the hospital. Some places like Oswego County, you can do that on the MDT, or you can verbalize that report, same information, just over the radio to the dispatch center, and they will send it by page to the hospital. If you go to a place like Madison County wants you to contact the hospital directly, so you are calling a specific phone number that will connect you to the emergency department, and they want a lot more information. So you speak one-on-one with usually a nurse, sometimes a doctor, and say that you have a 21-year-old female BLS care complaining of abdominal pain after she ate something that didn't settle with her stomach. She has nausea, vomiting, some diarrhea that's been going on for a day. Then these are the vital signs. So that's a lot more information that places in Madison County want from you. So learn your area and learn what your hospitals want from you in terms of the pre-arrival report. So I won't go into very specific details beyond that because it all depends on what area you serve or will serve. So that's something that when you join an agency, find out from the people in that agency, what do the hospitals that we go to want. That being said, pretty much across the board, if you have a critical patient, then you should be contacting the hospital directly and speaking to them and giving them a good amount of information. So if you have someone who was shot and is unconscious, call the hospital, let them know I have a 30-year-old male who was shot 3 times, once in the chest, once in the abdomen, once in the leg, has this amount of injuries. These are the specific vitals that we have. This is his mental status. These are the treatments I've done. I'm going to be to your facility in 10 minutes. So anyone who is critical, which is typically an ALS patient, but anyone who is beyond your scope to treat, you should be calling the hospital and speaking to them directly. Typically, my rule of thumb for that is if I think this patient needs immediate intervention when we get to the hospital, I should be calling them and letting them know. So these are patients like someone who's having a stroke needs immediate intervention as soon as we get there. Someone who's having a heart attack needs immediate intervention when we get there. Someone who has a major trauma. So anyone that we really need medical attention as soon as we get there, it's beyond the scope of what we can treat, you should be calling the hospital and giving them a more detailed report. So, like I said, stable patients require basic information. So your age, gender, whether they are ALS or BLS. You as an EMT will always be BLS. It stands for basic life support. Their chief complaint and your estimated time of arrival to the facility usually go in 5-minute increments. So 5, 10, 15, 20, 25, 30 minutes. More critical patients, you should say who you are and what level of provider you are. So when they pick up the phone, they'll say Kraus on. You say Kraus Hospital, Eves 2, which is my ambulance number, paramedic Buskey, how do you copy? So make sure that they hear you, because sometimes the connection isn't good. So either you might not hear them or they might not hear you. So that's your quick, hey, this is who I am. Are you hearing me okay? They should come back and saying loud and clear, so they hear us loud and clear. And then you can go ahead with what you need to say. So again, you want to let them know when you're going to get there. patient's age and gender, their chief complaint, what's going on with them, so their history of present illness, but keep it nice and brief. Any major medical history that might be pertinent. So if it's a stroke, say they've had 3 strokes in the past. Their basic mental status, the vital signs that you're finding, anything that you find in your physical exam that is pertinent for them to know, any treatment you've given, how they've responded to the treatment you've given, and any questions that you may have or that they may have. I usually end my report with saying, I am not requesting any orders, or I am requesting an order for this reason, but I'll usually say I'm not requesting any orders, just giving you a heads up about this patient. Do you have any questions? That allows them to ask anything that they might be wondering or something that I might have missed while giving my report. So those are some basic principles of giving medical reports. Good idea is to listen to some people do it first so that you can actually hear it in person and you can connect it to a patient that you're actually seeing. So when you contact medical direction, so that's when you're speaking directly to a doctor. You're usually doing this, if you're in Onondaga County, typically when you call a hospital, you're always speaking to a doctor. If you're in another area, you might need to say, I need to speak to a doctor for medical orders, and they'll go get one. But when you are speaking with medical direction for an order, make sure that you very clearly let them know what you want or that you're asking for their advice. So that's one of the first things that I come with when I'm talking to them is saying, I have a 38-year-old male, I am requesting an order for this on them. That way, the rest of the report that they're listening to, they are associating with, he's telling me this information because he wants this order. If I wait till the end to say what order I want, then they might be thinking a whole different thing from what I've been saying, and then I blindside them with, oh, I want to give this medication to this patient, then they have to go back and think, well, is this medication appropriate? So if you start with, this is the order I want, they are thinking the entire time, is this something I'm willing to order? So say I want to give 0.4 milligrams of nitroglycerin to this patient because they have chest pain, they have a history of heart attacks. They are not currently prescribed nitroglycerin, but I think that this would be beneficial because of this. These are their vitals. Then they can say, yes, I will give this, or no, you should not give this. So after you receive an order from them, whether that's an order to do something or them denying that you should do something, repeat back that order. So if you say that you're requesting an order for 0.4 milligrams of nitroglycerin to be given sublingually, they say, yes, go ahead with that medication. Say, okay, I will administer 0.4 milligrams of nitroglycerin sublingually to the patient. That way, there is no chance that either they misheard you or you misheard them. If you get an order that you can't understand, ask them to repeat it. And if the order does not seem appropriate, question the physician. I know that this seems a little weird that we as basic EMTs are going to be questioning the order that a doctor gives us, but the doctor only has the information that you are giving them verbally. They are not seeing this patient. They do not get to assess this patient. They are relying on your assessment tools. So if you forgot to tell them something or they misheard you for something and then they order something inappropriate, that's your job to say, well, I understand this is your order, but I don't think this is going to be good for the patient because they have this. And you saying that might cue them to be like, oh, I didn't know that they had this because they can't see the patient and they can't assess the patient themselves. So just because a doctor orders something doesn't mean it is necessarily appropriate for the patient. Usually it is, but there are instances that it's not. And you as the person who is giving this treatment to the patient or intervention or whatever they order, you are also responsible for making sure that they are getting appropriate care. So if they order something inappropriate and you do it, you and the doctor will be somewhat on the hook for this treatment, especially if it can be shown that you as the EMT should have known that that was inappropriate. So if you think that it's not wise, talk to the physician more about it. You can ask for clarification or say, well, I see this. Are you sure that's the appropriate treatment? Going on into our verbal report. Our verbal report is what we say when we get to our hospital, our destination. Or if you're in the fire department and you have an arriving ambulance crew, this is what you say to the ambulance crew. So whenever you're transitioning care to someone, you want to be giving a verbal report to them. In your verbal report, you want to include the history of present illness. So say what's going on with them, say your assessment findings, say your interventions that you performed, and the current vital signs. And if the vital signs have changed, especially due to your interventions, say what they were before and after. Same with if you have any sort of patient status change. Say you had a unconscious patient that wasn't breathing that you gave Narcan to, and now they're conscious, they're oriented, they're breathing fine. Say we found them like this, we gave them Narcan, and now they're like this. So give all your treatments, give all your assessments, and give any changes that you had during patient care. All right, so moving into some interpersonal communication. So the first thing that we need to think about with communication is communicating with the healthcare team. So this includes your partner, this includes other first responders on scene, whether that's fire department or police. This includes doctor's offices or any healthcare facility you might get someone from. This includes at home, a home healthcare aide, the family, bystanders, your hospital nurses and doctors when we get to the hospital, and pretty much anyone else that we might encounter involved in healthcare. So this is where we had to learn about medical terminology because you might be receiving information where they are using medical terms, especially if you go to a doctor's office or you are talking to another EMT or paramedic on scene. But you also need to be sure how to effectively communicate out. So be mindful of terms that you might hear and then terms that you should say. And keep in mind how you should briefly but effectively communicate with others. So if you're giving a report to someone else, you need to make sure that you are brief and concise, but that you hit all the highlights. So don't go into every single finding that you may have seen, especially if it's all normal. So instead of saying I assessed both legs, both arms, the chest, the torso, the neck, and that was all normal, the patient has a headache, just say patient has a headache. If something's normal, it's usually implied unless it's something that is very pertinent to the case, such as patients having chest pain, but they're not having difficulty breathing. So be sure that you know how to effectively communicate briefly with providers, especially nurses and doctors, and even a lot of paramedics are notorious for only listening for the first couple seconds to you. So if you can't effectively communicate the highlights in the first 5 seconds, they might not hear anymore because they just stop listening to you or they are thinking about something else. So when you are either giving report or you're receiving, make sure that you are respectful in your communication and that you speak very plainly. Don't use any term that might be confusing to whoever you're talking to. And make sure that you collect all the information needed about the patient. So ask questions. If someone is giving you a report on the patient, say you're at a doctor's office, and you have a question about what they told you, ask those questions. One of the most notorious things that we find in EMS is if we go to a nursing home and they give us a very brief report about the patient saying, oh, we called them because, or we called you guys because they had altered mentation. Then they leave it at that. Find out what's their baseline mental status like. And that's where they're notorious for being like, well, I don't really know this patient very well. I don't usually work on this floor, or I just started this shift, which begs the question, well, if you don't know them, why did you call for altermentation? That might be their baseline. But ask questions, and if they don't know, try to find someone who does know. So if you are at a nursing home and they say, well, I don't know the patient very well, politely ask them to find someone who does know the patient well so that you get all the information that you possibly can. Because when you get to the hospital, those are the same questions the hospital is going to be asking you. And if you can't tell the hospital, then that will delay the patient care, and the hospital will not think of you as highly as a provider because you don't know the information required to treat this patient effectively. The next part of communication is called therapeutic communication. This is communication typically done between us and our patients. Therapeutic communication comes with time. This is why experience is critical, because it takes time and experience to learn how to effectively calm someone down, effectively communicate with them in a way that they understand, especially if they're going through crisis. It's very hard to talk to a patient who is in distress, or talk to families that are in distress, and be able to understand what they will and won't hear from you. So when you first start this job, watch others and learn from them, both the goods and the bads. Not everyone is good with the therapeutic communication. That's something that me personally, I hear commonly from my partners that I'm not the best at therapeutic communication with a lot of patients. Sometimes I'm very good with it, but usually I'm not the best at it. So sometimes if I have someone who's new, they can learn, well, this what he didn't work very well, so I'm not going to do that in the future. But also find out things that do work well and use them in the future. So take the goods and the bads and learn from them when you're watching other people communicate with their patients. The number one rule, though, above all, is be respectful with the family and the patient, and act the way that you would want someone else acting towards you or your family. So if you think of, if your mother was in this type of distress, or if your mother died, how would you want your medics handling this? And try to act like that. Now, that will get you through a lot of situations, especially when you're new. Some key things that we should be doing when we're using therapeutic communication is use eye contact. Eye contact is a pretty universally accepted way of showing respect. There are some cultures where eye contact is discouraged, but for the most part, it is a known sign of respect. Some patients may need touch when you're communicating with them. That could be holding their hand, holding their arm, just putting a hand on their shoulder. Not every patient wants that, though. So take it with the general surroundings of the patient. If they ask to have their hand held, do it. Be aware of how your body language is presenting. You should be eye level with the patient, so you shouldn't be towering over them and being intimidating. You shouldn't have your arms crossed or on your sides, because that is very standoffish or might look like you aren't interested or that you're upset with them. So be very open with your body language. Don't be closed off. Act like you are very interested in what they have to say. So you can see this provider right here, he is at the patient's eye level and looking at the patient, so showing respect that he's hearing what she says, and he's holding her hand. So that is two very key aspects of some therapeutic communication, especially with the elderly. Elderly generally like touch to go along with their communication. Again, not everyone, and don't assume, but that is something that we do tend to see with the elderly. Again, use language that the patient can understand. Don't get your fancy medical terms out. Break it down into common language that patients can understand, and explain what you're doing to them. This can be especially important with pediatrics. Explain what you are doing to the patient before you do it to them. And sometimes you can do it to like their parent or to a stuffed animal. Just explain, this is what we're going to be doing. It's not going to hurt, or it might hurt a little bit. And that goes into our next point, is be honest with your patients. Don't lie to them. If something's going to hurt, let them know it's going to hurt. Don't say, oh, this isn't going to hurt, and then do something that causes a lot of pain, because then they aren't going to trust anything you say. A lot of patients will ask, am I going to be okay? Or did this happen to me? Is my leg broken? And it's important to know that we don't have the tools to give a definitive diagnosis. Sometimes we have a very good idea. So sometimes it's okay to say, well, we don't have an x-ray, but considering your bone is sticking out of your leg, I would say it's a good idea that it's broken. Take it within reason. So let them know if you are telling them what you think is going on, you can say, well, I think it might be this, but we are not doctors, we're just EMTs. We don't know this for sure. We have to get further testing to make sure of it. So you can say, well, your blood pressure is very low, so I think that might be what might be causing you to feel this way, but I'm not positive. We need to get more testing to figure it out. So be honest with them. You can let them know your thoughts, but absolutely do not give them the impression that that's the final diagnosis. And if you aren't sure, you can be honest. Say, well, we're not really sure right now. That's why we need to go to the hospital and have a doctor look at you to get a better answer of what's causing this. So don't lie to them, and don't overstep your reaches, especially if they're asking what's going on with you or with them. When you're communicating with a patient, use their proper name. So if they're elderly, using their last name, so Mr. or Mrs. and then the last name, that's usually a sign of respect. But that can differ between patients. Some patients don't like to have their last name used. So if you say, call someone Mrs. Smith and she says, oh no, call me Lucille, then call her by the name that she prefers. It's not a hard and fast rule that you have to use last names with every patient. So call them what they wish to be called, but start as proper as you can. So start with Mr. or Mrs. and last name, and if they correct you, then use what they want to be called. Also, listen to your patients. Like I said, doctors, nurses, and a lot of paramedics are notorious for only listening for 5 to 10 seconds to a report. They're also notorious for only listening for 5 to 10 seconds for what the patient's telling them. So try to not fall into that habit. Try to listen to everything that the patient is telling you, because they don't know how to prioritize their information. They might be really concerned about the toe pain that they have, and they're going to go on and on about that. And they're also having chest pain, but it doesn't hurt as much as my foot does, so I'm going to talk about my foot a lot more and not mention my chest until 3 minutes into me talking. So it's your job to listen to your patient, pick out the things that are important for you to know. This is also important to do with family or bystanders, because again, they don't know how to prioritize information. They're going to tell you everything, and you need to pick out what is important for you to know. So fully listen to what they're saying. Don't just tune them out. Don't start daydreaming about something else while they're rambling on and on and on about stuff that's not too important to you. Keep in mind that they don't know how to present that information in a priority sense to you. So listen to everything that everyone is telling you. Keep in mind that you have to tailor your communication to the patient. So if the patient has a mental disability, or they might have visual or hearing impairments, or they have a language barrier, you're going to have to tailor your communication to fit that. Never assume that the patient has one of these things at the start of a call, though. So if you walk in and you find a person who's 98 years old, don't assume that they have hearing loss and start screaming at them so they can hear you better. Start at a normal volume, and if they say, oh, I have a hard time hearing, can you please speak up? That's where you can repeat yourself at a louder volume. It's very disrespectful if you just assume that and you start yelling at them, and they think that you can't effectively communicate with them because of that. So always start at the minimum baseline and then tailor your communication based off of the information that you are presented with afterwards. Again, with pediatrics, we've talked about this several times. Come down to their eye level. Be very honest with them and speak in language that they can understand and keep it age appropriate. So instead of saying, do you have abdominal pain to a 4-year-old, say, does your tummy hurt? That's the language that they can understand and is age appropriate to them. Also, like I said earlier, it's critically important that we demonstrate procedures first because they are terrified of medical procedures. They are used to going to a doctor where they get shots and it hurts. So they associate medical providers with being hurt. So anytime that you go to touch them, especially with something that they've never seen before, then they are going to get very scared. So demonstrate something on their parent, demonstrate it on you. If they have a stuffed animal, demonstrate it on them. Show them that things are not going to hurt, or if they are going to hurt, be honest. Say it's going to hurt a little bit for a quick second. Say you had to get a blood sugar on the patient. Say it's going to hurt for a quick second, but then it'll be all over. So be very honest with them and try to demonstrate things ahead of time. So moving on into your pre-hospital care report. This is a huge part of EMS. So pre-hospital care report. The name implies what it is. It's all the care that happens before you get to a hospital. So this is what we as EMS providers do. It is a written document of everything that we assessed, everything that we did, and any response that the patient has. This becomes part of the patient's permanent medical record. It's also a legal document. So it's imperative that we fill these out fully with as much detail as possible and that we fill them out honestly. Pre-hospital care reports can be abbreviated PCR, so that's usually what people call them, or PCRs, or even more abbreviated, people will just call them a chart. Try to shy away from saying chart unless you're talking just to another EMS writer saying that I have to finish my chart on this patient, then they'll understand. But chart to a hospital employee might mean the hospital chart. So that's why PCR is a little more specific, because that is a pre-hospital care report. So they understand that is your side of things. There's two different types. There's handwritten and electronic. An electronic PCR is abbreviated E for electronic at the start, so ePCR. Most places in New York State have gone to electronic PCRs now. It is mandatory that even if you do a handwritten PCR, that gets uploaded online so everything can be accessed electronically. And the state is really pushing to make everything ePCR. There's also a thing called a drop sheet. It's a transfer sheet. This is if you are at the hospital. It is a New York State requirement that written documentation is left at the hospital at the time of patient transfer. So you are not allowed to leave the hospital in New York State without leaving a written documentation of what happened. That's where the drop sheet comes into play, because a chart usually takes a while to fully complete, especially when you're new. It could take you upwards of an hour to complete a chart. So you can't sit around at the hospital just charting for an hour because you might have other calls to answer. So this is where the drop sheet, where you do very basic principles of the call, that's handwritten. So the patient's name, their age, gender, vital signs, and what you did in the chief complaint. So very quick, leave that so that if there's any questions, there's a written form that says very basically what you did on the call. So again, that is a New York State mandate whenever you transfer patient care at the hospital. Some more New York State requirements. This is accurate as of May of 2021. The ePCRs, like I said, are highly recommended, but they are not required yet. But if you do a written PCR, you have to electronically upload it to the state's database. PCRs, regardless of whether they are an ePCR or a PCR, they have to be completed and uploaded within 4 hours of the completion time of the call. So when you are back in service, you have 4 hours from the time of being back in service to having your chart completed and uploaded. This must happen 90% of the time for the agency. So we understand if you do back-to-back calls, you might not have time to finish all your charts within 4 hours. But as a general rule of thumb, about 90% of the time that should happen. Regardless of getting back-to-back calls, every chart must be completed before you leave your shift. So even if your shift ended 2 hours prior and you got late calls that held you past the end of your shift, you must complete your charts before you leave the station, before your shift is officially over. So that is a New York State requirement that has to be done before you leave your shift. So like I said, your PCR becomes part of the patient's permanent medical record. So you have to be very descriptive and not leave anything out. So you have to document all your findings, all your treatments. You are describing the scene to whoever's reading the chart, whether that be hospital staff or your own CQI committee. So you have to be very descriptive and paint a picture of what you saw when you got to the patient. Remember, it is a legal document. It can either be used to help a patient if they need to win a case, or it can be used against you if you are proven to have negligence. So that is your lifeline to prove that you weren't negligent. It can be subpoenaed in criminal cases and used as evidence. I've had to testify before in homicide trials with my PCR because it shows what you saw on the scene, which could have been a crime scene. So be sure that you are very factual and that you're very descriptive. And oftentimes, if you're called to court, this is a call that may have occurred 1, 2, or even 3 or more years ago. And in that time, you've probably done a couple thousand calls since. So this is your way to remember what happened on the call that happened several years ago that you may not remember anything about originally. So your chart has to paint the picture for both a reader and for you if you reread the chart. This is also where we get our ability to bill patients. So you include their insurance information, contact information, so a phone number and an address to send bills to. This is how your agency gets funded for calls. So administratively, your chart serves a lot of important purposes to make sure that you actually get paid for the calls that you go on. We talked about this in our introduction section, but your PCR will be critical for education and research. This is where we can get statistics about what's happening with our agency or with our providers. We can tailor our education based off of this. And you can also track an EMT's personal experience, which we'll go over in a second. As far as CQI, so quality improvement goes, this is where we get to look to see how our providers are doing, is making sure that we are following the correct standards of care. This is where we can see that someone stood out and did a very good job, so we might give them an award for the care that they provided. Or this might be where we can identify, well, this provider is having a hard time with this type of call. Let's go over education for this type of call with them so that they can provide better care in the future. So like I said, your chart will help you provide personal tracking. So right here is a screenshot of me personally at one of my agencies I work at. This is an entire year's worth of calls and everything that I did for interventions. So I was able to very easily select the last year. So this was the year of 2021 and just say, show me all my procedures that I did. And so you can see right here are the amount of times that I did something successfully. So if I want to know how well I was doing with, say, intubation, you can see oral tracheal intubation. I successfully did it 6 times. This column is how many times I attempted. So I did it 6 times out of 7 attempts. So I was intubating people successfully 85.7% of the time. You can also look at peripheral IVs. This happened to be a very poor year for me, so I did 112 IVs with 156 attempts, so I was about 72% success rate for my IVs. I can also see all the different types of medications that I gave and how frequently I gave that medication. So I can see I gave epinephrine 21 times, or I gave fentanyl 11 times, versus I only gave aspirin 4 times. So I can see the types of interventions that I was doing. I can see how successful I was at those interventions, which is a very good personal tracking method. Like I said, 2021 was a very poor year for me IV wise, because I usually know I'm around 80 to 85% success rate. So I can start to think, well, why was my success rate much lower that year? I might tailor what I'm doing with my IVs based off of that. So very, very important to factually document all your procedures, especially if you have unsuccessful procedures. Not everything you do will be successful, especially if you get to the ALS level where you're doing things like IVs. You won't be perfect at putting IVs in every single time. So documenting your unsuccessful attempts as well as your successful attempts is crucial so that we can track things and start to learn personal performance. So we're going to kind of fly through this part. This we cover in class of actually going through how to make a PCR. But also when you're at your own agencies, have someone sit down with you and learn your own charting software and what you need in all there. I will put the disclaimer out there. Everyone will find their own personal style of documentation. There's no one right way to document a call. So one of the most helpful things you can do is when you're first starting out, look at a bunch of different people in your agency that you're going on calls with and look at how they document the call. So when I first started, I was reviewing the chart for every single call I went on, even though I didn't write them for a couple of months. And so I got 15 different styles of chart writing. I got to pick and choose the elements that I really liked that I saw from other people. So take all the information in that you can and pick and choose and make your own style. Again, there's no one right or wrong way to chart. So some elements that we need. You have your run data, so agency name, date, times, the call number, which is usually a run number, who was on the call, the levels of certification of those people, and any other information. It is important to use the official times given by your dispatch center, so don't make up your own times. That's why we tell our dispatch center that we're on scene, we are transporting to the hospital, we've arrived at the hospital. Those are the official times that if times for the call are subpoenaed, they are going to look at what dispatch recorded as your times, and they should match what's in your chart. So don't make up times. As far as patient information goes, include their name, address, phone number, gender, age, date of birth, their weight, their race, and their insurance information. Then you get to the meat and potatoes of your call. So give your general impression, the summary of what happened, give the patient's prior aid, their past medical history, physical exam results, vital signs. If you do a 12 lead, do say that you did it and what the interpretation the hospital gave. Again, we'll cover that in cardiology. Other procedures and treatments that were rendered, medications that you administered, and any other information that might be pertinent. And then make sure that you put in your transport information, where you went with the patient. As far as the narrative sections go, there's several different charting softwares out there. And so you're going to have to tailor your chart to what the software requires. Typically, some requirements that are across any different charting software is you want to include everything in a SOAP format. So SOAP stands for Subjective, Objective, Assessment, and Plan. So subjective is all the information that the patient tells you. Objective is everything that you measured and observed on the patient. Assessment is your full patient assessment. And then the plan is taking all the information saying this is what we're doing. So your treatments an intervention is rendered, and transport or refusal of care. So no matter what system you use, at some point in your chart, you should have all these things included in there. Some general rules of thumb for your narratives: avoid abbreviations, especially when you're new. Try avoid any abbreviation until you learn what is a standard one to use. Write legibly if you're using handwriting, and this is so important. Use correct spelling and grammar. Remember, this is a legal document. This has to be read easily and it has to be accurate, and it is a reflection of your care. So if you have a sloppy PCR with a lot of spelling and grammar errors, it's going to reflect that maybe you were giving sloppy care. You weren't paying attention and giving careful attention to your detailed care because you weren't giving careful attention to your detailed documentation. And remember the rule that if you didn't document it, you didn't do it. Your documentation is proof that you did procedures. So if you put a C-collar on a patient that had C-spine compromise, but you didn't document it, and then they come back and sue you saying that, oh, you didn't take good care of my neck and I got hurt because of that. If you didn't document, you put a C-collar on that, there's zero proof that you did that. So you have no case to prove that you were not negligent to the patient. So make sure that you document everything you do. If it wasn't documented, it wasn't done. Another great rule to follow is do not lie or attempt to cover up mistakes. Mistakes happen. They do. We are human. It's called medical practice for a reason. No one is perfect at it. We understand that mistakes can happen. What we can't understand is you trying to cover up your mistakes. If you do perform or make a mistake or you forget to do something or anything like that, don't lie about it or try to cover it up. Usually, if you make a mistake, we'll just try to remediate you and give you some education so that you don't make that mistake again. If you cover it up, that's a completely different story. Most of the time now, if the only way you lose your EMT card or paramedic card if you go to become a paramedic is if we can prove that you were trying to cover something up. If you are honest and forthright in coming and saying, hey, I did this and the patient may have suffered because of my actions, we're understanding of that. But if we have to find out that something happened and you didn't document it properly or you lied about it, that's where we can't trust you to provide care anymore. So that's where you might actually end up losing your certification, is if you lie or cover something up. So just be honest. Be a person of integrity. That's what this profession demands, is integrity. All right, moving into some special documentation stuff. So legally, your PCR is confidential. It is covered by HIPAA. We discussed HIPAA in section 1. If you breach HIPAA, that could mean mostly civil, but even sometimes criminal penalties for you. So it could be devastating if you breach HIPAA. So you have to keep your charts very confidential. You have to keep them secure. There are many, many guidelines to how we have to protect patient information. If you have a written documentation, it has to be locked and secured and not easily accessible. So one of the biggest things that we do is we might have our written documentation or documents from like the hospital that we keep on a clipboard, and then we leave our clipboard either on the counter at the hospital, or even worse, and this is very common, you can leave it in the front dash of your ambulance, and you go and you stop and get food on the way back, and someone can look right through your windshield and see all this covered information. So be very cognizant of anything that has patient information on it and how you store it. Moving on to some more legal stuff, patient refusals. So refusals of care is where we are not transferring care to someone else. We are leaving the patient wherever we found them. If you are to be sued in EMS as a provider, the vast majority of the time, it's because of a patient refusal. It is the by far the most highly litigated area of what we do. So we have to be very careful in our documentation, and we have to fill out a refusal of care form. So those, go to your own agencies and have them show you what a refusal of care form looks like. Make sure it's filled out completely and that you have proper signatures where the signatures need to be. When you're doing refusals, there are some very important things that you have to document in your chart. So you have to document that the patient had the mental and legal capacity to refuse care. You have to document that you offered that care multiple times to the patient and that they understood you were offering that care. You have to document that they understood the risks of refusing care, and those will be up to and including death, because we can't see everything that's going on with the patient. So they might die if we leave them there. We can't see the insides of them because we don't have the proper tools. So understand or document that you told them the risks and that they understood the risks. Document that you communicated with them that they should seek out immediate medical care if they change their mind or if their condition changes. So let them know, just because you're saying no now doesn't mean you can't call us right back. And then document how you left the patient. Did you leave them in the care of a family member? Did you leave them by themselves? Did they say that they were doing follow-up care? Did they say that they were going to the hospital in their own vehicle? So say how they were left and any follow-up care that they might be doing. So those are all critical parts that you should include in every patient refusal. Some more legal issues, as we said, falsification, so either covering up errors or recording something that you forgot to do or assess. Never do that. There are times that you might have an error in your documentation. That's okay to correct. That's what we call an addendum. So you don't delete what you originally wrote, but you can add to it. So you put out your whole PCR and then you put out a separate document saying, in addition to the PCR, I need to include this information. Sometimes that information is to correct something that was put in wrong in your PCR. That is fine. Again, as long as you do not delete and then retype something to make it change, you can add something and say, well, this was documented incorrectly. This is what was meant to be there. That is fine. So a chart has to be filled out for every single run an agency goes on. Even if you are dispatched and canceled by dispatch 2 seconds later, a chart should be filled out for that run. So that brings us to the huge debate that still goes on to this day with experienced providers. So every single time you encounter a patient, you have to either transfer the care to someone else, whether that be a hospital or another agency, or they have to refuse your care. So that brings us to the question, what constitutes a patient? If you are called to a patient who fell out of bed or slipped out of bed, they are not injured, they just can't get themselves up because they're 80 years old and they don't have the muscle capacity to stand up at baseline, so they call you for a lift assist and are not injured and they only want to be picked up and put in bed, is that a patient? And the answer is yes. If you have someone that you encounter that you assess at all, that is a patient. So anyone that you speak to, you have begun an assessment on. So that is a patient. You should have them refuse care. If you are called for someone who looks like that they are unconscious and they're on a park bench and they were just sleeping, have them refuse your care. Say, well, someone thought that you may have been unconscious. Just let me do a quick assessment, make sure you're okay, and then you can refuse any further care. Have all the refusal stuff filled out for every time that you encounter a patient. And if a patient refuses to give you their personal information or sign a refusal form, that's okay. Document them as a John Doe or a Jane Doe. Document all the information that you could have obtained and say they refused to sign the refusal form. That's fine. Say that you had this person, you don't know their name, but this is your assessment on them. This is all the information you found out, and then they refused any further care. Don't say, oh, well, they didn't want anything to do with us, so we aren't going to document anything that we did on this call. Document every single encounter that you have. So, you respond to a call for unconscious male. Upon arrival, the patient is awake, alert, and walking away. He states he was just sleeping and does not need or want treatment or transport. Is this a patient? Like we just discussed, you talk to him, you technically start an assessment. He is a patient. Is a complete assessment and physical exam needed? If he doesn't want it, no. You don't need to do a complete and full physical assessment and exam. Should you document this call as a patient refusal? Absolutely. And should you obtain a formal patient refusal? Try your best. Say, well, can you just sign here saying that you don't want anything to do with us? Most people will do that. Some won't, but most people will. And if they won't, say, you can fill out the refusal form and just say they refuse to sign. In the CNY EMS region, which is a region that covers Oswego, Onondaga, and a lot of the North Country and a little bit south counties, there's a box that you can check saying patient refused to sign form. So you can fill it out and just check the box saying that they refuse to sign that form. So document this as a refusal of care because they are refusing your care and there was a patient you were called to assess. Some special situations you're going to run into. Multiple casualty incidents. That is where you have more patients than you can handle on your own. So maybe you come to a car accident, you have 15 people injured. We'll talk about this more. We actually have a day dedicated to MCIs. So they become a logistical nightmare for us. And you can't take time to document all the care that you rendered before you transfer patient care off. So we do have some special rules governing MCIs where verbal report takes precedent. So say I did this to the patient, here you go, they're your patient now. And written documentation isn't necessarily needed for every single encounter that you have of every single patient on that one scene. So we'll discuss this a lot more when we actually talk about MCIs. So some special reports that you have to do. If you are exposed to infectious disease, we're going to have special reports. That's something you can find out from your agency of who to contact when you are exposed to infectious disease. If you injure yourself or another EMT gets injured, there are some special reports. Again, go to your agency about how to handle that. Sometimes that report has to go to police if someone injures or assaults you. Hazardous or unsafe scenes. Again, refer to your own agency. Referrals to social services agencies. Again, refer to your agency. And then mandatory reports for child abuse. Every EMT is a mandated reporter. So if you see any child abuse, you are mandated to report that. You have to go through mandated reporter training for the state of New York. Your agency is responsible to make sure that you do that before you go on the road. If you see child abuse, you have to report that within, I believe, 24 hours of the call. So just do it as soon as you're done with your chart. There's a special form that you have to fill out. Then you have to call that number to report the abuse, and then you have to send that form in. So all that's covered in your New York State mandated reporter training. Make sure that you do not provide care as an EMT on the road before you complete that training. All right, so moving on to some chapter review. We might be flying through this a little bit faster than normal. Remember, when you're giving a full report to the hospital, make sure you include your unit identification, what level of provider you are, whether you're EMT basic or paramedic, estimated time of arrival to the hospital, patient's age and gender, their chief complaint, brief pertinent history and history of present illness, major past illnesses, mental status, baseline vital signs, pertinent findings, your care given, their response to your care. When you're doing your PCR, make sure you include billing and insurance information, the nature of the call, mechanism of injury, the location where the patient was found, treatment administered before arrival of the EMTs, signs and symptoms you see, baseline and subsequent vital signs. Secondary assessment, care administered and the effect that it had. Changes in condition throughout the call. And remember, a PCR is a legal document. It can be called to court. The data from PCRs will help determine research stuff and help you find some quality improvement areas. Remember that it should paint a picture of the patient and their condition. This is a picture that will be used for CQI, the patient, lawyers, and you. Keep in mind, emergency medical communication comes in many forms and is essential to the team-based patient care. The medical radio report is structured to present pertinent facts about the patient without providing more detail than necessary. A proper verbal report will include the chief complaint, any history that was not given previously, additional treatment given, and additional vital signs taken en route. Interpersonal communication is often challenging in EMS. Adopting best practices can improve communication capabilities significantly. Confidentiality, patient refusals, and falsification of records are all important legal concepts that an EMT must consider when documenting a call. How can you improve your interpersonal communication with patients and team members? This is something that we should be considering after every call. How can we improve our communication? And remember, what is objective and subjective information in the narrative portion of the PCR? Remember, subjective is what the patient tells you, and objective is what you see. So this was a quick exercise we did in class of how to organize information. All right, so that brings us to the end of this. Again, this is more of a hands-on one where we get to actually go through charts. It's important that you learn your agency-specific documentation requirements. When you first join an agency, find out what software is used, or if you use paper charting, what elements are needed in charts, and then develop your own style of charting. And also keep in mind that communication is key to what we do, both talking to patients and talking to other providers. So this is very, very, very critical to have down. It's not something you're going to master immediately, and it's something that everyone, including myself, can improve on over time. So that brings us to the end of this chapter. If you have any questions, again, feel free to reach out to me, and we'll see you next time.